all present here. I'm Dr. Aishwarya Velli. I'm the third year postgraduate belonging to Professor Dr. Lakshmi Ma'am's unit. I'll be presenting a case on intractable seizures and laryngeal stridor. What could it be? So we had a 5-month-old female child who was the firstborn of third-degree consanguineous marriage. She was born out of full-term LSCS. She cried at birth. There were no history of NICU admissions. Developmental milestones were attained appropriately up to 5 months of age. The child attained social smile at 2 months of age, head control at 3 months, rolling over from back to side at 5 months. The child did not have any family history of seizures. So on the first admission, the child, this is the photograph of the child. This child presented to us with complaints of multiple episodes of seizures with no apparent provoking factors. The semiology of seizure was a vacant stare. Each time the seizure episode lasted for around 5 minutes, after which the child regained basal level of sensorium. The mother did not notice any abnormal odor of urine. The mother did not give any history of lethargy during times of acute febrile illness. So on examination, the child was alert, awake. The child did not have any neurocutaneous markers. She did not have microcephaly. Systemic examination was normal. There was no organomegaly. And CNS examination did not reveal any focal neurological deficit. On investigating the child, since she presented at 5 months, we first ruled out all the electrolyte disturbances. Serum blood sugar was normal, calcium was normal, all the electrolytes were normal. Then we thought about inborn error of metabolism, so we did ammonia and lactate, which also turned out to be normal. CSF analysis was done in order to rule out GLUT1 deficiency. CSF glucose was also normal. The EEG was normal. MRI imaging with MRS also turned out to be normal. Optal opinion did not reveal any characteristic findings. Urine metabolic screening was normal. TMS at this point was planned, but we weren't able to do because of social reasons. Treatment of the child apparently presented to us in the case of unprovoked seizures. We had query metabolic seizures and query genetic epilepsy at this point of time. She was initially started on one long-term AED, phenobarbital. Even after that, the seizure episodes persisted. So we had to load the child with a second long-term AED, levetiracetam. At this point of time, we considered other factors like pyridoxine deficient seizures. So we started the child on pyridoxine trial. There was only partial response to the pyridoxine trial. So we considered folinic acid responsive seizures and we added on folinic acid also. At this point of time, there was decreased frequency of seizures and the mother wanted the child to get discharged because of social reasons. So the child was discharged with phenobarbital, levetiracetam along with pyridoxine and folinic acid. After 4 months, that is at 9 months of age, the mother brought the child back to us with complaints of respiratory distress this time, noisy breathing, hypotonia, and the child did not attain any milestones after 5 months of age. The mother also gave a history of loss of already attained milestones. There was also persistent but reduced frequency of seizures according to the mother. There was no history of fever, cough, or fast breathing to account for the respiratory distress at this admission. There were no history of previous nebulizations. At this point of time, on examination, the child was awake, afebrile. The child had stridor. There were no added sounds. Minimal subcostal retractions were present. The child did not have any neurocutaneous markers, no organomegaly, no seborrheic dermatitis or alopecia. Tone was decreased in all 4 limbs. DTS were normal. Plantar was bilateral extensor, and pupils were equally reacting to light. So for the stridor part, the X-ray turned out to be normal, and the pulmonology opinion to rule out any anatomical cause of stridor also revealed that it was just a neurogenic stridor. At this point of time, since we had already planned for TMS, thinking that it might be an inborn error of metabolism, we proceeded with TMS, and the tandem mass spectrometry revealed elevated methylprotonyl carnitine and isovaleril carnitine with profound biotinidase deficiency. This is the TMS report. Sample for serum biotinidase levels were sent, and the child was started immediately on biotin supplementation at 10 mg per day. The subsequent assay of serum biotinidase level showed profound deficiency. There is less than 10% of the enzyme activity. The value was just 0.45 nanomole per ml per hour. No further seizures after starting the child on biotin. Pyridoxine and folinic acid have already been tapered off, and we are during subsequent visits. So biotinidase deficiency, it is an autosomal recessive disorder with an incidence of 1 in 61,000 live births. The gene responsible for biotinidase deficiency is BTD gene located at chromosome 3p25. The major manifestations can be neurological, dermatological, and respiratory. Neurological manifestations include seizures, hypotonia, developmental delay, neuroregression, ataxia, visual problems including optic atrophy and conjunctivitis, and sensory neural hearing loss. Dermatological problems include alopecia, seborrheic and atopic dermatitis, recurrent viral and fungal infections due to immunological dysfunction. Respiratory problems include laryngeal stridor, hyperventilation, and
icon zoom right corner. Right side Bluetooth icon
yourself, please.
That's zoom.
I've highlighted all the major manifestations that was present in my case: seizures, hypotonia, neuroregression, and laryngeal stridor. In the side, I've given the frequency of occurrence of symptoms according to Pompenio et al., a study which was done in 1997. It showed that seborrheic dermatitis has the most common manifestation of biotinidase deficiency with an occurrence of 67%, alopecia around 59%. But this child did not have seborrheic dermatitis or alopecia. Rather, laryngeal stridor, which is quite a rare representation, that is just 13% of the cases, was predominant in this child, along with intractable seizures. So this is the biotin pathway. Normally, why is biotin important? Is biotin, it combines with the lysine residue of apoenzyme in order to form a holoenzyme. This holoenzyme is responsible for taking part in the catabolic pathway of leucine, isoleucine, and valine. After the four main carboxylases that are involved is acetyl-CoA carboxylase, pyruvate carboxylase, propionyl-CoA carboxylase, and 3-methyl-propionyl-CoA carboxylase. The point is, after this function, biotin needs to be resynthesized so that it can be reutilized for the next cycle. But for that, the enzyme that is required is biotinidase. So when this is deficient, there will be an accumulation of the metabolite that is present in the previous step, that is bioscitin, as well as biotin will not be resynthesized, as a result of which there will be biotin deficiency. It is also interesting to know that even after we start the child on biotin supplementation, biotinidase enzyme level is still going to be reduced. So when we suspect biotin deficiency in a child, we can very well start the child immediately on biotin and then send a sample for biotinidase levels. So diagnosis is by enzyme assay. We can define it as profound deficiency and partial enzyme activity. Profound deficiency is less than 10% of the enzyme activity, whereas partial deficiency is 10 to 30% of the enzyme activity. Also, molecular genetic testing can be done to find out the biallelic pathogenic variants in the BTD gene. Major differential diagnoses include nutritional biotin deficiency, holocarboxylase synthetase deficiency, zinc deficiency, and essential fatty acid deficiency. Treatment, biotin supplementation needs to be continued lifelong. For the dose is at least 5 to 20 mg per day. It needs to be remembered that biotin administration allows the complete remission of clinical and biochemical abnormalities except for hearing loss and optic atrophy. The developmental delay part, it actually varies from patient to patient. So it's always better to start the suspect it early and start the child early so that we do not affect, the brain is mainly affected during the first 2 years of life. But it's always better to start the child on biotin supplementation early. So what is the take-home message from my cases? What we already know, intractable seizures plus seborrheic dermatitis or alopecia, we always suspect biotinidase deficiency and we start the child on biotin. So what was new is intractable seizures without any seborrheic dermatitis and alopecia, but presenting with laryngeal stridor and hypotonia. Even then, we have to suspect biotinidase deficiency. Why is it so important? Because biotinidase deficiency is a correctable cause for intractable seizures. These are my references which show that